introduction. A very brief introduction. It's actually a joyous moment to have this presentation because Zinat and Montazir have been working very hard on this analysis for a while. But as many of you will know, this is the kayak study that Mary McBride started several decades ago now. And this is the continuation of that, looking at the longer term incidence and mortality of the kayaks cohort in British Columbia. So I will pass you over now. Thank you very much. I think it's Zinat first and then Montazir.
Okay, I will start. Hi, everyone. Good morning to those joining from the western part of Canada and good afternoon to those in the east. Today, I will be presenting alongside my colleague Muntasir Rahman on the 50-year trends in incidence and mortality among childhood, adolescent, and young adult cancer survivors in British Columbia. Before we begin, I would like to express my gratitude to Dr. Stuart Peacock, Head of Cancer Control Research at BC Cancer, and Dr. Meera Ryer from BC Children's Hospital, both of whom are the co-PIs of the Kayaks program, and to Agnes Lai, who is a cancer surveillance and outcome analyst at BC Cancer Research Institute. It has been a privilege to work under their guidance. Also, I would like to acknowledge that as a first-generation immigrant, I'm privileged to have the opportunity to live, learn, and present today on the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. The structure of today's presentation is as follows. We will begin by discussing the formation of the Kayaks program in BC, its aims and objectives, and how this particular study fits within the broader Kayaks framework. Next, we will outline the methods used in this study and then present some key findings, starting with the results from the adolescent and young adult cancer survivor group, followed by the childhood cancer survivor group. Finally, we will wrap up with conclusions from the study and discuss some potential directions for further research before opening the floor for questions. There are some of the terminologies that we will be using throughout the presentation. I'd specifically like to highlight AYA, which will stand for adolescent and young adult. I would like to start with a brief overview of cancer statistics in Canada. Researchers estimated that there would be 247,000 new cancer cases and 88,000 cancer deaths in Canada in 2024. Among these total cases, 127,000 will be males and 120,000 will be females. When we look specifically at the adolescent and young adults, the Canadian Partnership for Cancer reports that roughly 7,600 Canadians between the age of 15 and 39 are diagnosed with cancer each year. In fact, just last year in 2023, an estimated 9,000 people in this age group were diagnosed with cancer. Additionally, for childhood cancers, about 1,500 new cases are diagnosed each year in Canada. If we just focus on the absolute numbers, the burden of cancer might not seem particularly high in this specific group. For example, in Canada, the 5-year survival rate for childhood cancer has increased by 71% since the late 1980s. Similarly, in USA, for AYA, the 5-year survival rate for those diagnosed between 2008 and 14 was 86%. This is up from 71% AYs diagnosed in the mid-1970s. In fact, over the last 5 decades, advances in cancer treatments and supportive care for children and adolescents have led to a growing population of survivors reaching adulthood. But despite these encouraging survival rates, this population faces a high risk of late occurring health problems, including significant morbidity and even early mortality. It is estimated that approximately 2/3 of the kayak survivors will develop at least one side effect from their cancer treatment. Many will die before they reach the age of 40. There is also a risk of long-term health and social issues, including cognitive and socio-developmental impairments, which can further impact the quality of life as they age. Since there is a critical need to address several aspects of survivorship for this population. First, we need to comprehensively estimate the risk of late effects and long-term health and social problems that the survivors may face, It is also important to determine their health and social resource needs related to cancer to better support them. Developing and evaluating strategies for long-term management is essential to improve their quality of life. Lastly, as survivors age and new cancer treatments are introduced, we must stay vigilant in identifying new health conditions that may arise. But how do we document the evidence which will enable us to transform policy, practice, and change? One of the most cost-effective ways to gather comprehensive long-term outcome data is through the use of population database and record linkage methodology. This approach allows us to assemble large cohorts and track their outcomes over time with minimal loss to follow-up. It also minimizes the potential selection bias, which can often occur when active participation is required. In recognizing the gap in information about long-term sequelae and care for kayaks in British Columbia and the need to provide evidence to support strategies for system-related policy and practice changes, a multi-project longitudinal cohort program known as the Kayaks program was established under the BC Cancer Research Institute, where we tapped in the rich administrative data source that BC has to offer. Here is a brief overview of how the Kayaks program has evolved. Initially, under the Kayaks 1 program, the cohort included all individuals who were diagnosed with cancer or a tumor before the age of 25 and survived for at least 5 years. The cohort consisted of survivors who were residents of British Columbia at the time of their diagnosis and covered the period from 1970 to 2005. With the new Kayaks program, several updates have been made. The age range has been expanded to include individuals from birth up to 39 years old. Additionally, the data has been updated to extend the cohort period from 1970 to 2020. The timeline for the Kayaks 2 program is structured as followed. Right now, we are at the first 2 years of the study, which is focused on acquiring data from various sources and developing or modifying database structures. Year 2 to 4 will involve record linkages, which will be updated, and analysis will be conducted for project 1 and 2. The projects will be examining the late effects on physical and mental health and investigate the patterns of healthcare utilization among healthcare survivors, including physician, hospital, mental health, ambulatory, and pharmaceutical use. From year 4 and onwards, we will focus on ongoing quality management and further data analysis to inform policy and practice. Kayaks 2 program will leverage the rich population, clinical, and health services datasets available in British Columbia. The data on survivors will be collected from the BC Cancer Registry and linked across multiple sources. So the first is the BC Ministry of Health, and then the Ministry of Education and Children, which will provide achievements and assessments, Statistics Canada, which will offer income data, and Works of BC, which will contain injury reports and compensation data. Additionally, the client registry from the Ministry of Health will serve as the source for the control cohort. This cohort will be linked to treatment and health outcomes data, aiming for a 1 to 10 case control ratio to ensure sufficient statistical power for assessing multiple determinants. In 2023, we received the updated dataset from BC Cancer Registry on the survivor cohort, which contained around 60,000 cases. We only took the first incident case if on the first incident date, people were diagnosed with multiple cancers. We considered all those cancers as cases, and we ended up having 49,466 survivors in this cohort. Using ICD-03 codes available in the dataset, which is the International Classification of Disease on Oncology, we then classified the data into 2 groups, AYA and childhood cancers. For AYA cancers, survivors aged 15 to 39 years, we used the SEER, Surveillance Epidemiology and End Results Program, AYA site record, updated from the ICD-02 and ICD-03 definitions. For childhood cancers, we use the International Classification of Childhood Cancer classification based on the ICD-03. This system emphasizes on tumor morphology, primary site, and tailored specifically for cancers in individuals under 15 years and above 15 to 39 years of age. It helps define major cancers affecting AYAs and childhood cancers and supports reporting on cancer incidence and trends. After recoding the ICD-03 codes to AYA and ICCC codes, we further only took the cases who survived more than 1 day in terms of the gap between diagnosis and date, and ended up having 43,588 cases and for the AYA cancer survivor group and 5,600 cases in the childhood cancer survivor group. Using the available data from the BC Cancer Registry that we have in our hand, we conducted a study with the objectives of providing a demographic overview of both childhood and AYA cancer survivors, breaking down cancer types according to ICCC and CR-AYA classifications, analyzing trends in cancer incidence and mortality in British Columbia over the past 50 years for these age groups. I will now hand over to Muntasir, who will go over the methods part of the study.
Thank you, Zinat. If you can go to the next slide, please. So coming to the methodology, the number of cases of cancer by sex and time period was found to be statistically different or independent. And we used the chi-square and the t-tests for that. We calculate the incidence and mortality rates with regards to BC's population in the corresponding children or AYA age groups, and age standardize them using the 2016 Canadian census population as the base. AYA cancer rates are per 100,000, and childhood cancer rates are reported as per million. Male to female ratios calculated in the studies was based on the absolute case count numbers. Next slide, please. So we estimated the trends in incidence and mortality using the US National Institute of Health's SEER program-built joint point software. It gave us an established means to conduct the trends analysis. The joint point method characterizes a trend using joint linear segments on a log linear scale. The points where two segments meet is called a joint point. The software calculates the annual percentage change, or APC, for each joint point segment, and also provides the average annual percentage change, or AAPC, over the entire period being analyzed. Each APC and AAPC is accompanied by a 95% confidence interval. This is especially important for cancers with small numbers, as it can be difficult to distinguish between differences over time based on random variations from true differences when the number of cases is small. Next slide, please. A drawback of the joint point method is that the software is unable to estimate trends if the count is 0 for any particular year within the time period being analyzed. So in such cases, we were unable to analyze trends for certain cancers, or we conducted a partial trends analysis, i.e. not across all 50 years. Some of the parameters and assumptions of the models are listed here. So for instance, the model assumes that the incidence and mortality counts follow a Poisson distribution. We set the maximum number of joint points to the highest level as suggested due to our long time frame. And the software chose the specific regression model using the weighted Bayesian information criteria. The 95% confidence intervals were estimated using the parametric method. We also selected the uncorrelated errors option after conducting sensitivity tests to check for the impact of possible first-order autocorrelation. And I will hand it to Zina for the results, the AOA.
So adolescent and young adults diagnosed with cancer face unique challenges. I liked how Ferrari and colleagues correctly noted that AYA patients are in a sort of no man's land. AYAs are heavily impacted by the lack of integration between pediatric and adult oncology, resulting in significant gaps in care and inclusion. Recognizing that AYA cancer patients have distinct psychosocial and supportive care needs, we decided to conduct a separate analysis focusing on the AYA incident and mortality trends. I will start with the results from AYA cancer incidences that we found in our study. So this study includes 43,588 AYA patients with cancers diagnosed between 1971 and 2020. There were more female survivors than male survivors, and the number of incidents rises with age, with 35 to 39 years old having the highest incidences. And in all age groups, female are significantly more likely to develop cancer than male AYAs, other than the 15 to 19 years age group where males are higher. The decade from 2011 to 2020 saw the highest number of cases identified by which is 23.4%. Compared to the consistent increase observed in the first cancer cases from 1971 to 2000, the 2001 to 2010 cohort demonstrates a slight decline in proportional representation. This is explained by the fall in cases between 30 to 39-year-olds. As there were many cancer subtypes under the ICD-03-based CR-AYA cancer diagnostic groups, we focused our analysis on the 16 cancer subtypes with the highest overall incidence and 9 cancer subtypes with the highest incidences separately for female and male survivors. If we just look at the top cancers, among all malignancies combined, the highest proportion of cancer was observed in breast cancer, testicular cancer, and carcinoma of the genital sites, excluding the ovary and testes. For female, the most common cancers in the past 50 years are similar, with breast cancer, carcinoma of other genital sites, and thyroid cancer topping the list. For male, testicular cancer, carcinoma of gastrointestinal tract, and lymphomas were the most common ones. Apologies for the bright streak of colors in this slide, but I want to compare the overall cancer trends in BC, in particular comparison to data from the USA, and just try to match the colors that they used in that study. This study, which is in the left, they looked at the population-based cancer incidence in USA around 2012 to 17 and found the proportion of cases similar to ours, with breast, lymphomas, and thyroid cancer at the top of the list. However, in our data, if you see the red one in the right, we see that there is also an increase in gastrointestinal cancer, which was not as common in USA. In fact, earlier this year, Colorectal Cancer Canada also provided similar statement where they showed that the incidence of cancers among young adults under 50 years of age has rapidly climbed in recent years, challenging the conventional perception of this disease as being a disease of older adults. We also look at the male to female ratio in absolute numbers of each major diagnostic subgroup of first cancer incidences over the last 50 years. We can see that male AYAs have higher incidence, as noted by ratio greater than 1, in carcinoma of urinary tract, head and neck cancers, astroglial and related neoplasms, Hodgkin's and non-Hodgkin's lymphomas, where females have higher incidence in all other major subgroups provided here. These results are comparable within other studies done in USA and some of the European countries. Previous research links higher urinary tract cancer rates among males to differing carcinogen metabolism and potential effects of the sex steroid hormone pathway, contributing to this increased male incidence. In contrast, we also see that there is a higher absolute incidence of thyroid cancer among females, which in the literature is primarily attributed to their more frequent diagnosis of small, non-threatening thyroid cancers. This graph shows the standardized incidence rates per 100,000 Canadian population for top 16 disease sites with the highest absolute incidences for all adolescent and young adults in the last 50 years. And the trends are similar even after standardizing. After age standardization, this graph reveals in the left the trends in female cancers, with breast cancer showing highest incidence, as we observed before too, for the 50 years, followed by carcinoma of genital sites and thyroid. And previous studies showed that changes in reproductive patterns, such as declines in the fertility rate and older age at first birth, are the driving forces behind this rise in breast cancer rates in females. In the right, we see testicular cancer is the most common one, with rates increasing more rapidly than other cancers for males, followed by gastrointestinal tract cancers and lymphomas. Moving to the joint point analysis, this graph shows the results for the overall cancer trends from 1970 to 2020. We can see that between 1971 to 1994, there was a notable rise in overall cancer incidence with an annual percentage change of 1%. Although there was a brief period of insignificant decline, this upward trend persisted into recent years, specifically from 1997 to 2020. This recent trend matches with the trends in incidences in AYA cancer in Ontario and Alberta. This is actually the main results section. Among the top 16 cancer subtypes, 7 displayed a statistically significant positive annual percentage change in average. In terms of APC, annual percentage change per year, 5 major subtypes, breast, testis, urinary tract, lymphoma, Hodgkin's lymphoma, and acute myeloid leukemias have consistently increased over the past 50 years. Thyroid and gastrointestinal cancers, marked in green, have also demonstrated a positive APC with a noticeable increase over the past 40 years. The substantial increase in thyroid cancer, as I have mentioned before, primarily non-threatening papillary thyroid cancers, highlights a potential overdiagnosis issue, which is talked a lot in literature. This suggests an urgent need for more cautious diagnostic practices while addressing the growing burden of thyroid cancer in BC. The increase in gastrointestinal cancers may be explained in part due to the nature of the disease in AYAs, who are often diagnosed with more aggressive forms of the disease, perhaps due to a delayed diagnosis. In more recent years, marked in blue, pituitary neoplasms and lung cancers have shown rising incidence rates. For cancers for genital organs, we also see an incidence rates are falling until 1984, but have since risen. This trend could be linked to changes in diagnostic practices, evolving risk factors, or demographic shifts. However, after all this negative news, there are some positive news in the incidence trends too. While 2 cancers, malignant melanoma and ovarian cancers, exhibits a significant decline in the past 50 years. Again, this pattern is consistent across what other studies in Ontario and Alberta have observed. The stable incidence of ovarian cancer among younger females may be partly attributed to the consistent use of oral contraceptives and changing fertility patterns. These trends emphasize the complex interplay between healthcare practices and cancer trends, warranting ongoing research and adaptation of screening and diagnostic strategies. I would also like to note that the objective of this research was not to pinpoint the underlying risk factors driving these cancer trends, but rather to present the current landscape of cancer incidence. This foundational understanding can pave the way for more focused research in the future. Now, when stratified by sex, the previously described trends for overall cancers were observed for both sexes. Overall trend in male and female cancers are also rising significantly in the past 20 years. I'm not going to spend more time here other than focusing on the fact that the trends in overall cancer persists in trend in major cancer in females too. We see a significantly positive increase in incidence rates for thyroid cancer, gastrointestinal tract cancers, and lymphomas, while the incidence in ovary cancer showed a positive decline until 1990. There is no significant trend in females in recent years. For males, we redid the joint point analysis focusing on them. And apart from the gastrointestinal cancers, we observe a sizable increase in the burden of testicular thyroid cancers in males, which is comparable to the global trend. The hypothesized factors contributing to testicular cancer involves exposure to endocrine disruptive chemicals and marijuana use in the environment. In the next couple of slides, I will briefly go through the results on the mortality trends in AYA cancers. The total number of deaths among AYAs with cancer from 1971 to 2020 was 6,825. Male AYAs, despite having a lower cancer incidence compared to females, have a higher mortality. Research using USCR program also found that mortality was much higher in males relative to females for a majority of the cancer types. This trend is observed for all age groups except among 35 to 39 years old, in which more females with cancers are dying compared to males. The highest proportion of total deaths in AYAs with cancer was between 1991 to 2000, which was much higher compared to the most recent decade. For mortality analysis, we focused on the top 8 cancer subtypes with highest overall mortality and 4 cancer subtypes with the highest mortality for female and 3 for the male survivors. When looking at the male and female ratios in mortality, there are marked disparities by sex for several cancers. For instance, death among male AYAs with non-Hodgkin lymphomas far outstrip females. These patterns are also observed in Hodgkin's lymphoma and astroglial neoplasms. These results show the standardized trends in mortality per 100,000 for top 9 cancers for all malignancies combined. We see a spike of blood and lymphatic vessel tumors, which is marked in blue, around 1991 before the rates dropped down. However, we could not include it in our joint point analysis as the mortality rate was 0 for many of the time periods. These graphs show the trends in age standardized mortality rates for the top 4 disease sites with the highest absolute mortality for female. I compared the results with the trends with the same study in USA that I showed before, which looked at the mortality trends from 1975 to 2017. The study found that breast cancer mortality rates are no longer decreasing in AYA women after more than 2 decades of continuous decline, likely reflecting the increased incidence. However, in our study, there has been much more fluctuations, but overall, breast cancer mortality rates are still decreasing. These graphs show the trends in age standardized mortality rates per 100,000 for the top 3 disease sites with the highest absolute mortality for male from 1970 to 1971 to 2020. I also compared them to the same study, and the results show similar trends to ours. Mirroring incidence, colorectal cancer mortality rates likewise increased approximately 1% in USA, which is also true for a study with a higher mortality rate in gastrointestinal cancers in BC. Overall, in joint point analysis, it showed 3 joint points. The trend in mortality rates have significantly decreased from 1993 to 2006 with an annual 4.13% change, but has not had a significant decline after that period. There has been a general decrease in the all-cause mortality rates of AYAs with cancer in BC, with a similar to overall trends across Canada. In breast cancer, the rising trend in breast cancer AAPC is driven by the astoundingly high mortality rates between 1970 to 1975, whereas the current trend through APC annual percentage change shows that significant fall in the mortality for breast cancers. This is likely due to the improved overall cancer control, including increased mammography screening and the use of more effective therapies following breast cancer surgery. There is a significant reduction in the annual percentage change of mortality among AYAs diagnosed with non-Hodgkin's lymphoma, lung cancer, and acute leukemia. Also, although average annual percentage change in gastrointestinal tract is significantly positive, it doesn't show any significant trend in APC in recent years. In this graph, where we stratified the mortality trends by males and females, we see a significant decline in the left for the female AYAs, which started from 1977. But the same trend is not observed for males. These are the stratified joint point results for females, which I would not go over, as the findings are similar from the overall trend analysis. And this is the one for males, where similar to the rise in incidence in gastrointestinal cancers, we do observe a significant rise in mortality in recent year with an APC of 1.7%. In summary, the increasing cancer burden among AYAs in BC, marked by the rising incidence and mortality of gastrointestinal tract carcinoma and the growing incidence of other subtypes, particularly thyroid cancers. Our findings highlight that sex disparity that exists for certain AYA cancers and reiterates the need for more granular analysis and policies, especially for cancers that have shown limited improvements in survivability. I will now hand it over to Muntasir.
Thank you, Zeenat. So we're now moving on to childhood cancers. And as Zeenat mentioned before, childhood cancers were classified using the International Classification of Childhood Cancers, which categorizes cancers into 12 major and 47 minor or subgroups. Next slide, please. So I'll skip over this, but only will say that, cancer in children presents itself very differently compared to other age groups. And our knowledge of childhood cancer etiology is still lagging behind other age groups. So given the relative rarity of cancer in children, research into treatment and survivorship have proven difficult in general due to the small cohort sizes. So this study aims to provide support to this field of evidence. Next slide, please. So our study includes a total of 5,051 boys and girls between the ages of 0 to 14 as the childhood cancer cohort, with 2,700 boys diagnosed compared to around 2,300 girls. This is different than the AYA cohort, where the females had the greater cancer incidence. This ratio is comparable to that of Ontario's and similar countries like Australia, China, and many European countries. The US, in comparison, has a comparatively closer sex ratio when it comes to childhood cancer. We also see that the absolute cases of cancers has been increasing over the last 5 decades, with the highest number of cases diagnosed between 2011 to 2020. Next slide, please. So here, I've presented all 12 of the major cancers under the ICCC classification. We also have data on the 47 subgroups of cancers, but I'm not presenting them here so as not to clutter the slide. In terms of percentage, it is perhaps not surprising to see that the top 3 cancers in children are leukemias, followed by CNS tumors and lymphomas. Neuroblastomas, soft tissue sarcomas, and renal tumors are also quite frequent. Next slide, please. This graph shows the age-standardized incidence rate per million of the top 7 most frequent major cancers in BC among all children. So even after age standardizing, the top 3 cancers are the same: leukemias, CNS tumors, and lymphomas. Next slide. This is a graph showing the age-standardized incidence rates of the top 7 most frequent cancers by sex. The top 3 cancers are still the same for boys and girls, with the incidence rate values higher in boys compared to that of girls. Next slide. I thought some comparisons would be of interest for our audience in Ontario. So I found average incidence rate values for childhood cancers in Ontario between 1986 to 2015. from the 2018 and 2020 POGO surveillance reports. As shown, during the same period, the incidence rates for BC and Ontario were largely comparable, though lymphomas and CNS tumor incidence were somewhat higher in Ontario, and the disparity in cancer incidence between boys and girls was also higher in Ontario. Next slide. The line graphs seem to show that the childhood cancer incidence in BC had more annual variability compared to Ontario for all cancers combined. It is similarly the case for leukemias. Next slide. Lymphomas are an interesting case, given that there seems to be some dispersion in the incidence rates during the last decade or so between BC and Ontario. And CNS tumors on the right also show more variability in BC and a reduction in the latter years. Of course, these are just some quick comparisons of incidence rates I made for this presentation, and no analysis has been conducted to check whether these differences are statistically significant or not. Next slide, please. Now, moving on to the trends analysis of childhood cancer incidence. Given the smaller numbers of cases in childhood cancers, even over the 50 years we're considering, we were limited in the kinds of trends we were able to analyze. We see that the trends for all cancer incidence combined was linear, i.e. there were no joint points, unlike that for AYAs, and that the trend is increasing. Cancer diagnosis in children increased by 0.42% per year on average over 1971 to 2020, and this was statistically significant. This increasing incidence trend is seen in other provinces as well as in many other comparable Western countries. Next slide, please. Likewise, the AAPC, the average annual percentage change for boys and girls, are both positive, though it looks like the average rate of increase is slightly higher in girls. Next slide. So a more in-depth look at the trends found that the incidence of cancers has increased at the highest rate among 5 to 9-year-olds. Leukemias overall increased at 1.6% annually on average over the whole 50-year time period, though between 1980 to 2020, it increased at a lower average rate of 0.6% per year on average. And the higher 50-year trend is affected by the very high per annum increase between 1971 to 1980. Now, considering that childhood cancer etiology is still largely unknown, at least compared to cancers in older aged populations, the exact cause of these changes are hard to pinpoint, and we do not analyze any data to try and do so in this study. However, literature suggests that these changes may be due in part to the changes in cancer classification over the years, increased usage of advanced diagnostic methods, and better reporting of cancers. Studies have shown that certain genetic disorders, cytotoxic alkylating agents, certain environmental risk factors such as radiation exposure, etc., may lead to increased risk of developing leukemias. Fetuses and younger children are more susceptible to such exposures because they have higher intake rates due to having a lower body weight and because their detoxification mechanisms are still underdeveloped. Studies have also shown that maternal age is associated with the risk of childhood cancers, with the risks found to be increasing with maternal age for the top most frequent cancers among children, with the average age of first-time mothers in BC being the highest in Canada at 32.4 years in 2022. This is an area that merits some exploration as well. Socioeconomic factors also seem to play a role. For example, a study in Manitoba found that areas with higher immigrant population also had higher rates of childhood leukemias. CNS tumors had a statistically significant increase per annum of 0.7% on average between 1971 to 2015. The incidence of CNS tumors may actually be decreasing in the last 5 years, though this is not statistically significant. As with other childhood cancers, genetic and hereditary conditions may increase the risk of CNS tumors. Increasing risk or exposure to ionizing radiation and environmental factors such as pesticide and pollution exposure have also been linked to CNS tumors. The incidence of malignant bone tumors increased quite rapidly between 1971 to 1989, though has decreased since then. Next slide, please. A loose comparison of our trends data with the Canadian data is presented, though to be clear, the periods in consideration are very different, so no direct comparison is possible. The trends in all cancer combined between BC and Canada as a whole is somewhat comparable. There are some differences by sex, though it looks like cancer incidence in girls has been rising quite rapidly in more recent times in Canada. And this supports the incidence trends for cancer in girls in BC being higher than boys, despite boys having higher cases of cancers overall. Cancer among 5 to 9-year-olds is also relatively higher in Canada and is the case in BC as well. Next slide, please. Now we move to exploring all-cause mortality among children diagnosed with cancer. So there were a total of 1,033 deaths, with more boys dying than girls. The highest frequency of deaths in children was between 1981 to 1990. Looking at number of deaths by sex, age group, and decade, our data shows that more boys diagnosed with cancer have died across all age groups and decades, except in the 0 to 4 age group during the last 3 decades, where more girls died. Next slide. This graph shows the annual age standardized mortality rates of the most frequent childhood cancers. As we see initially, the highest mortality rates were among children with leukemias, but in the last 2 decades or so, mortality rates among children with CNS tumors have been higher. Though in the last few years, that seemingly has decreased. Next slide. So this is by sex, where the picture is similar to that of the overall mortality by cancer type. Next slide. But thankfully, the trends of cancer mortality has been a decreasing one overall. The trends graph shows that the age standardized mortality rate has decreased by an average of 1.94% per year between 1971 to 2020. And this is a statistically significant decrease. Next slide. This has been the case in both boys and girls, though the rate of decrease is higher in boys compared to that in girls. Next slide, please. So given the small numbers of childhood cancer mortality and with many years with 0 counts of deaths for particular cancers, this joint point analysis of mortality rates is not as comprehensive as the incidence rate trends. However, broadly speaking, we found that the largest reduction in mortality was for those in the 10 to 14-year age range, and the least reduction on average was for those in the 5 to 9-year-old age range. In regards to the types of cancer, reduction in mortality in children with leukemias may be the biggest contributing factors to the overall decreasing in mortality rates, because between 1971 to 2008, BC saw an average annual decline of 4.3% in mortality rates among those diagnosed with leukemias, which is quite notable. This rate is especially noteworthy compared to CNS tumors, which declined by only 0.79% on average. Next slide, please. So in summary, to wrap up, the results of the 2 studies attempt to shed some light on the long-term trends in childhood, adolescent, and young adult cancers in BC between 1971 to 2020. We found that in both cohorts, the incidence of cancers are generally rising, while mortality has fallen in the last 5 decades. In general, female AYAs carry a larger cancer incidence burden than males, though it is the reverse in the 15 to 19-year-old range. This ties in with the results showing that boys carry a greater incidence burden of childhood cancers than girls, and that there's a transition period where the sex disparity reverses. This points to the need to assess these 2 cohorts separately. In AYAs, we found significant increasing incidence rates, notably for thyroid carcinoma and gastrointestinal cancers, among others. Next slide. In the children cohort, there were significant increases in the incidence of leukemias, CNS tumors, and malignant bone tumors. Male AYAs and boys both have higher mortality counts compared to females. Male AYAs had a non-significant reduction in mortality trends in the last decade, though this was a significant reduction for boys. There was a rise in deaths from gastrointestinal cancers in male AYAs, while mortality fell across all categories assessed for childhood cancers. So one clear strength of the study is being able to use a data set that has data over such a long time period. However, as is often the case, there was some missing data for which we had to drop some of the observations. The SEER joint point software is unable to handle missing or zero count data, which restricted our analysis. The mortality counts are all-cause mortality. And statistically speaking, some cancer categories have small numbers, which increases the possibility of false positive or false negative results. Next slide. So to conclude, we hope that based on some of the patterns of cancers from these studies, we can focus on broader evidence-based research into specific cancer types. And the long-term aim of the KAIAX program is to increase usage of the KAIAX-2 dataset to improve our understanding of late effects and health outcomes in the CAYA population. Slide. Thank you very much for listening, and thank you to the CCSRC for inviting us today. I realize that this was a lot of data to sort through, but we would welcome any questions or recommendations. Thank you.